So now, earlier you were saying that the mainstay of treatment is the immunomodulators because they've got a great history. Some people don't respond to them and you need to use stronger measures. What percentage of people, do we have a good handle on that, of what percentage of people do respond to the immunomodulators versus the percentage that needs stronger treatment?
Well, that's a whole, you've just raised a whole big question about how do you define response, which is difficult to get into. I like to think of there's two types of responders. True responders and false responders. What's a false responder? Take a patient group today, put them in a placebo-controlled study, you follow them for a couple of years. Interestingly, 20, 30, even 40% of the placebo, these are patients taking nothing. They don't have any attacks, they don't have any new MRI lesions, they show no evidence of progression. If they were on a therapy, you would say, oh, see, that's a wonderful therapy. They're a false responder because you're measuring response by the lack of development of new things. But we don't know what the natural history is for any given individual. Maybe it would be 3 years before they got an attack. So that's the false responder, and we have to always keep in mind that that's a group that we don't know. Right. The true responder is someone who's not having all those events because you picked the right medicine for them. Right. Great, but you can't tell the difference from it. Non-responder, is there a cure? Are any of the medicines that we have curative? Can you cure diabetes? No, you can control diabetes. Can you cure hypertension? You can control hypertension. So there are going to be some people who are going to have some kind of disease activity. And if what you're looking for from the treatment for MS is 0, that's the cure. Well, we can do that actually in extreme cases. But for the most part, the therapies are aimed at minimizing the development of new activity. And we have to define the limit. And then if you exceed that limit, you're a non-responder, okay? So this is where you use some of the other therapies.
Okay, so briefly, we've talked about how some people don't respond to immunomodulator agents, the common ones like Copaxone and Avonex. The stronger therapies that you talked about for people who are not responding, who are breaking through that. Can you tell us just a brief picture of what that looks like?
Well, each of these drugs that have been developed, first of all, very few of them have been tested to show that they're actually stronger. When we talk about escalating therapy for patients, we're really talking about using drugs that have the potential of causing more concern. So why expose yourself to an agent that may kill you in some cases or develop lifelong problems as a result of taking that medicine if you don't need it? So if the modulators are working for us, we hold the course, even if they might be inconvenient. If they're not, you move to some of the other medicines that we have that work differently, but bring to the table some new problems. You have to, it's benefit and risk, right? So is it worth taking those drugs in an effort to try to control the disease? Well, sure. I mean, if this disease is escalating and what we're seeing is early disability coming on, and you're talking about a young person in the throes of their career, this is not an opportune time to become disabled. They're going to become more desperate. They're going to use these therapies. So the question comes, if you're going to use it, are you stuck on those for the rest of your life? We don't think so. Just like we do with other diseases, we try to pick something that a patient can stay on. And if the disease escalates, think of Crohn's, think of rheumatoid, you add these medications. Well, we haven't been able to do that in MS. And you know what the number one reason is why? The drugs are so costly today, and we recognize that although it might be in the best interests for patients to actually combine therapies, we have not been able to do that in MS simply because of the cost. But I see this coming as some of the immunomodulators are going to become generic. We will be able to start combining medicines, and it's the combination of medicines that have really made a difference in so many other diseases. This is the future for MS.